Hello, everyone. Welcome to this episode of the Sheriff's Mic, Clear to Talk with me, your sheriff, Corey Honea. You know, in law enforcement, it is not uncommon for us to deal with people who are dealing with mental health issues, addiction, and there is clearly an intersection between mental health, addiction, and public safety. And so I am really glad to be joined today by our Director of Behavioral Health here in Butte County, Scott Kennelly. Scott, this is an important topic that I think that a lot of people are interested in and maybe aren't as familiar with as they should be. So I'm glad to have you here. Thanks for coming in.
Thanks for having me. I'm pleased to be here.
Fantastic.
Looking forward to our conversation.
So let's start off with this. Why don't you tell everybody a little bit about what the Behavioral Health Department does? It's a big department. There's a lot of things going on. You have your fingers, so to speak, in a lot of different sectors, and I think it'd be good for people to have a better understanding of what it is that your department does.
Sure. So Butte County Department of Behavioral Health is the second largest department in the county behind Department of Social Services. We have about 425 people or positions in our agency. We are tasked with providing mental health and drug and alcohol services to members of the community who are seriously mentally ill or seriously addicted to substances, who also have Butte County Medi-Cal or are considered indigent and have no other means of insurance or payment source. So we serve as a safety net to provide services mostly voluntary in nature. However, there are components of our programs that are involuntary in nature, which require higher levels of care, such as hospitalization. We also do a lot of early intervention and prevention services in the community in various locations like the schools, homeless camps, shelters, wherever the need arises, including we have a mobile crisis team that goes out anywhere in the community if someone is in a mental health crisis and responds.
Yeah. So you talk a little bit about the voluntary services, and certainly if someone is in need, what would be the way that they would make contact with your department to start accessing those services?
Funny you said access. That's the way to get in.
Okay.
It's to call our access line, which is 530-891-2810. You could also drop into any of our clinics. We have outpatient centers in Gridley, Chico, Paradise, and Orville. So you just need to request the service. We'll come in, we'll do either a phone screening or a screening on site to determine what your needs are. And if you qualify for our services, we'll initiate the paperwork to start opening services. One thing that's different about behavioral health in California is several years ago, the state divided up who's responsible for mental health care, and so gave the health plans individuals who have what they call a mild to moderate impairment. They're struggling with a little bit of anxiety, depression, maybe some blues. They are the responsibility of the health plan, and in this case, Butte County is Partnership Health Plan, and they have a network of care throughout the county, but we've been tasked with the severe population. So that's individuals who are really struggling in some areas, be it vocational, they can't obtain or maintain a job, housing, they're having difficulty maintaining housing, social skills, they're having difficulties in interpersonal relationships with others, a variety of areas where their mental illness or their addiction is impacting their life in a way that they're struggling.
So it's interesting you say mental health and addiction because I think we often find both of those conditions occurring simultaneously in individuals that we deal with. One of the things that was curious about what you said is the health plans, and explain what those are a little bit, if you could, for people who aren't familiar with what that is.
So historically, the health plans were Anthem Blue Cross and California Health and Wellness, and they were responsible for the physical health of individuals with Medi-Cal, Butte County Medi-Cal. Okay. And they had a network of care that provided medical, dental, vision services, and they contract with places like Ample Health, North Valley Indian Health, the hospitals, anywhere you need physical health services and mental health services for mild to moderate conditions. They left our county last year, and Partnership Health Plan replaced those two plans. So they are the only health plan for Butte County Medi-Cal residents and provide a lot of the services that I've talked about, including the mild to moderate services in the county. If someone does come in for services with us and has a mild to moderate mental health issue and chooses to stay with us and not go the other direction, that the state has something called no wrong door. Okay. So in either way, if they also went into partnerships plan and they were severe but wanted to stay with their network, they could choose that. Yeah. So there's a little bit of choice there.
So mild to moderate, is that based on a particular diagnosis, or is it based upon how the person is able to navigate the world?
More the latter, their ability to function in society.
Okay.
So you can have a depression diagnosis and it can be a mild depression, or you can have a severe depression. So it's not necessarily the diagnosis; it's how you're managing or how those symptoms are impacting you.
Okay, so would the same be true? Let's say a person has a diagnosis of schizophrenia, but they're able to manage it and navigate in the world fairly well. That might be considered moderate, depending on how they're able to do. Is that?
Yes. So success for us is we treat someone with schizophrenia with psychotic features, severe impairment. We stabilize them. They get on medication. They're functioning better. And our goal is to hand them off to the health plan to allow for less restrictive services, and their impairment is more mild, so that we can take more severe individuals on the other end.
Yeah.
So there is a flow that happens, but it also is bidirectional. Sometimes the other thing happens where someone's in partnership, their primary care provider's doing their services, and they're like, whoa, this person's really struggling. They maybe need case management or more intensive support, and they refer to the county.
Got it. So you talked about the people who want to access those services voluntarily, but there's also a group of people that require treatment, and that's involuntary. They're not willing to volunteer for it, but they need it. Can you give some examples of when a person might need involuntary treatment?
So there's a couple programs we have.
Okay.
Some of them are criminal justice programs.
Yep.
We have a mental health court, we have a drug court, we have a care court, and we have now a Prop 36 process where individuals are compelled to receive treatment for their mental health or addiction issues because they've had some kind of criminal justice activity, which I'm sure you can speak to better than I. They've broken the law, and they're offered a choice: go to jail or come into treatment. And so there we have teams that serve that population. We work in partnership with law enforcement and public defender's office and the courts to try and help restore them or help them stabilize. And in that case, they're voluntarily receiving services, but there's a hook attached to it, strings attached.
Kind of a carrot and stick approach.
Yes.
Yeah.
There are a number of voluntary services we do, but also the involuntary component is when we come across someone, typically in crisis, that is considered a danger to themselves. They're suicidal, they have a plan, they want to end their life, and they perhaps have a weapon in mind. They're a danger to others. Due to the nature of their mental illness, they want to hurt someone. There's a plan too. Or they're considered gravely disabled. They can't provide food, clothing, or shelter to themselves, all due to the nature of their severe mental illness. They can be assessed and placed on what's called a 5150 and detained for up to 72 hours for evaluation and treatment in a hospital. And that hospital that we operate locally is our PUF, or Psychiatric Health Facility, a 16-bed inpatient facility. However, we also hospitalize a number of people that go out of county to out-of-county hospitals, including youth, because there is no youth inpatient facility at this time.
Got it. Well, and what you've highlighted there is this intersection between the criminal justice system, law enforcement, and behavioral health. And it's interesting to me. I've been working in law enforcement for over 30 years. And back when I was a deputy working on the streets, we would occasionally encounter somebody who we believed was suffering from a serious mental health issue. That seems to have exploded. Now it is common for my deputies almost on a daily basis to deal with people who are suffering from, significant mental health issues. Often addiction is part of that as well. Why do you think that is? Why has there been an explosion in the number of people suffering from those kinds of conditions?
There's no easy answer.
Okay.
There's multiple factors. I'd say a lot of it has to do with the number one piece for me is substance addiction.
Okay.
The drugs you and I knew about when we were teenagers, the low-grade marijuana that you'd be happy if you found are not on the streets right now or available. There's hardcore, high-potency marijuana at this point, with 90% THC or higher. There's kratom, bath salts, which are not illegal drugs that are easily accessible. And there's a lot of hardcore things like fentanyl and xylazine and other drugs that you can access with the touch of a button. Your cell phone now can get you literally a DoorDash delivery of drugs if you need it. And so access to high-powered drugs is having a significant impact on people, both homeless and not homeless. Addiction is happening a lot faster, and also psychosis. In the old days, when you'd take meth over time, you'd see people in those pictures of that person with the meth and the gradual transition, and you're like, and now look at them now. you can get there within 6 months in some cases, or even less with some of the drugs that you're taking. So we're having a lot more people who are taking drugs for the first, second, third time, the harder core drugs, and that light switch is clicking on, and psychosis or mania or aggression starts kicking in. You're also having a situation where the homeless population is shifting.
Okay.
There's been a lot of outreach to the homeless population, and the individuals post-campfire, people who've lost their jobs, people who've had medical issues, those are the low-hanging fruit. They tend to get help. They want help. They get off the streets. The remaining individuals on the streets, there's a component of them that is not interested in getting help, doesn't want to follow rules, and has things such as anosognosia, where they have no insight into their mental illness. I know you love that term.
I heard you use that term a number of times. Exactly.
And or their addiction is so severe, they are no longer interested in finding shelter or getting out of their homeless situation. All they care about is their next hit.
Yeah.
And their prefrontal cortex has absolutely been hijacked. So the only thing that they care about is where their next hit is, and those drugs are available very easily within a block, typically, because there's dealers on the streets and around. The other big thing for Butte County is we have some of the highest ACE scores in California, which is ACE means Adverse Childhood Experience, the term. That means you grew up as a child in a home-like situation where there was abuse, there was drug addiction, there was violence, there was divorce, there was traumatic stress, and those kids are marinating in that stress, and their neurochemistry is changing, and their resiliency is not necessarily there, and so they're at very high risk for developing a mental illness and or an addiction disorder. And so a lot of those kids without interventions early upstream move on and manifest mental health or addiction issues. And then I see another reason we're having a lot of mental health issues is there is no shut-off valve for stress.
Okay.
I can go online at any time during the day and see murders and deaths and traumatic events. I can hear tweets and posts from people that say very inappropriate things. It's very hard to escape the stress and the negativity and the sense of impending doom sometimes that you get on the internet. And a lot of our kids and our adults are seeing that and accessing that, and that is not good for them.
Yeah.
So it's a much more stressful world, I'd say. You'd hear about a school shooting or a murder here and there because you'd read about it in a paper if you were lucky. Or I wouldn't say lucky.
I understand what you mean. Yeah,
but
exactly.
Now it's like I turned on the news this morning and I found out that there was a plane that crashed in San Diego and there's homes on fire and there's dead people, and I found out about a shooting, and it's constant.
Yeah.
So there's definitely more people that are more stressed, that are manifesting mental health and or the need to use substances, and then substance addiction issues.
Yeah. Man, there's a lot to unpack there. And
quite a bit.
Yeah. And I agree with your statement that there's no easy answer, but there are some pretty clear conditions that are present today that weren't present 30 years ago that, just logically would add to it. And I think you covered a lot of those. I'll start with the no way to turn off the stress piece. And you're absolutely right about that. I think it's interesting. I think the way that social media has developed, it's pretty clear now that they developed those platforms to become addictive so that people would continually refresh and scroll and follow those things. And it's hitting the same part of the brain that drugs hit. Is that your understanding as well?
Dopamine receptors. Yeah. You're getting your little rush.
Yeah. And you're right about the fact that you can get into this scenario where you think the world is full of nothing but bad and evil and tragedy because that's what's constantly hitting your brain, right? To the exclusion of all the other things that are going on, which is stressful, absolutely. In particular, I think it's harder to be a kid today than it ever has been because they are so saturated with that kind of thing. And I think it's got to have an impact on the way brains are developing. Would you agree?
Absolutely. And I don't want to underemphasize or underestimate the impact of COVID-19.
Sure.
Massive amount of isolation. People went into their screens, spent all day on their screens. But as far as a kid, I agree with you as well. Bullying is another new level. When I was a kid, being bullied was a matter of, where'd you go? What hallway did you go down? Where were the bullies? Now it's available on your phone. There's revenge, pictures. There's all sorts of things that are happening online, and it's pretty traumatic how it's impacting kids.
Yeah. Well, every time you answer a question, you have more things that I want to talk about. So
okay, I'll stick to the subject.
Don't stick to the subject. I think that's what makes this. That's what I like about this kind of forum is we can really explore it. because I do want to get to the other things that you mentioned, because I have some pretty strong opinions about that and want to highlight that and talk a little bit about that. But you also, mentioned COVID-19. And I think in retrospect, in my view, the way in which California in particular, and perhaps the country, handled COVID-19 in the long term was extraordinarily detrimental to many, many people. And I believe that it became politicized, and there was a myopic focus on COVID-19 and its impacts on health, filtered through that political lens to the exclusion of all other health-related matters. And I think we're seeing the negative consequence of that, which will probably last far beyond the threat that COVID-19 initially presented. I don't know if you want to comment on that, but
no, I'd agree. Yeah. And post COVID-19, you have different factions of individuals who have very strong opinions about COVID-19 and the vaccine, and including a faction of people who, if you're talking about mental illness, believe COVID-19 causes mental illness.
Yeah.
And unfortunately, the research that they're showing is not validated research. And as far as we're aware, there is no direct correlation. However, the social impact, all the stress that we've talked about, absolutely has a contributing factor.
Well, especially when you're talking about kids or relatively healthy people, forcing them into that isolation when the threat probably wasn't as extreme as other people with conditions that made them susceptible to that, again, did more detriment to overall society than what we're dealing with. And it's unfortunate because now we're dealing with these impacts, and they're serious. They are resulting in a lot of pain and suffering and death beyond what the initial problem was.
Yes, and the lack of ability to go and socialize and have normal conversations face-to-face with people, that's a critical developmental need for both teens and for adults that we lost out on for several years.
Yeah.
And again, people went to their screens, and that's how they had interactions, and that's not the same thing as you and I sitting down face-to-face and having a conversation.
Exactly. It is not an adequate alternative to real in-life personal interaction, right?
Great.
So now we talk about the drug piece, which I agree with you. Similarly, what we were dealing with 30 years ago in a law enforcement capacity with regard to drugs is different than what we're dealing with today. And you talked about the potency of drugs or the formulation of drugs that we're dealing with now. The methamphetamine that's on the streets today is different than the methamphetamine that we were dealing with 30 years ago. Now it is almost exclusively being produced in Mexico and brought across the border by cartels and distributed through their network. And we are seeing the same kind of thing, this almost immediate addiction that you talk about, and the kind of violent outbursts or violent results that we're seeing as a result of that, I think is increasing significantly. You talked about fentanyl, right?
Yep.
And fentanyl is killing people at extraordinarily high rates, which is tragic. And what is interesting about that is I think a lot of that has to do with bad public policy that was part of California's landscape, Proposition 47, which regrettably was implemented by the voters of the state of California, hopefully recently fixed by Proposition 36. But we start with that in terms of making the possession and use of drugs less of a legal threat. I think in many cases that opened the door for more availability, which we're starting to see. And all of this, again, losing sight of the fact that these policies have really impactful. They really impact the way people live and the way that people are dying, unfortunately. Yeah. Agreed.
And with regards to Prop 47, I agree with you. Prop 36, which supposedly corrected Prop 37 or 47, while I think the law passing was great, the state did not fund it.
Correct.
There's no funding to support the treatment that needs to happen for this population who's now going to be court-ordered to get help. So I think the state is far behind the ball on what needs to be done in many areas such as that. Don't pass a law that requires people to get treatment and don't fund the treatment teams or the probation officers or the people needed to make them successful.
Well, absolutely right. And again, that's a political issue at the
Correct.
state level. The people of the state of California recognized the dismal failure that Prop 47 was. They recognized that theft was skyrocketing, that drug addiction was skyrocketing, that we were seeing all the negative impacts, and they voted overwhelmingly throughout the state of California to change that course. But people in the state of California's governor, in fact, was adamantly opposed to that. And now we're in a position where the will of the people isn't being carried out because of political ideology. And it's sad because there are people who are suffering in our streets because of it.
Agreed.
Yeah. So it's a much, much more challenging environment, both for law enforcement and for mental health clinicians today. And the intersection between our worlds is, again, almost daily. And you talked about people coming to your department through the court system after having been arrested and things of that nature. But there is a on-the-street, day-to-day, boots on the ground interaction. And you talked a little bit about it when you're dealing with people who are in crisis and because of a mental health issue pose a threat or danger to themselves or others. That ultimately require us to work together on that. And I want to talk a little bit more about that in a minute, but I still want to flesh this whole this idea of the prevalence of mental health illness or mental health conditions within the community. Your perception now, how prevalent is mental health or mental illness in the general population now?
So I'm going to give you a number, but I'm going to tell you it's underrepresented.
Okay.
The only way we get data is from people self-reporting.
Okay.
And because mental health and or addiction has such a high stigma attached to it, people tend to underreport or not report at all.
Okay.
But the most current data says that 1 in 5 individuals in the United States has or will suffer from a mental health condition at any given time. That number, I'd say, is probably way too low.
Okay.
At any given time, I'd say 3 out of 5, even 4 out of 5 people has some kind of mental health condition, life event that causes them to substantially feel more depressed or anxious or anything like that. So the numbers, I think, are much higher than what the statistics say.
Okay. And that could be what you would characterize as moderate to all the way to severe.
If you go all the way to mild, you could say 5 out of 5. Literally,
at some
people
point.
could at some point in their life have a mental health condition that they're struggling with.
Sure. And is it fair to say that that's just part of the human condition?
Yes.
Yeah.
Absolutely.
Right. Which is interesting because if it's part of the human condition, the stigma associated with it is unfortunate, right? Because if we're all going to be dealing with that one time or another, we should be in a better position to recognize that and move forward with it, right?
Absolutely. We should not shame anyone for struggling post-divorce, post-job loss, something's happening in their life. And if it's mild, most people don't, and they recognize and they rally around and support people. But if it tends to be more severe, you get over it. Suck it up. It'll get better. Or you're going to go see a head shrinker or a psychiatrist? The terms alone sometimes are very demeaning for people.
For sure.
But yeah, at any given time, there are mental health issues that people are struggling with in their life. And for us, our big challenge with anything in behavioral health is working with the community and reducing stigma and raising awareness. We recently had an ad campaign. Did you know?
Yes.
If you saw bus stops and billboards and ad campaigns, a lot of data, statistics around mental health and addiction. That was a very controversial ad campaign.
Yeah, I heard.
Yeah.
Yeah.
Some people loved it and said, I'm glad you're talking about it. I'm depressed. I have a family member who's got schizophrenia. I had a great opportunity to talk to my kid about what suicide means. Other people were up in arms like, how dare you post this? What are you trying to do? You're trying to drive tourism away. You're scaring kids. Don't talk about mental illness or addiction. We want to talk about good things. Just get it away.
Yeah.
And so it was quite a mixed bag, but it did what it was supposed to do. It raised awareness, got people talking, and the calls to our access line and requests for services increased. So more people were calling us saying, tell me about what services you have. I have some questions about addiction or mental illness, or I want to get help for myself or a friend or family member. So in that case, it was helpful.
Sure. So You and I talked a little bit about the pushback that you had gotten on that, which I thought was curious. I suspect strongly that you didn't just wake up one day and go, "Hey, let's just do this ad campaign called, Did You Know?" There had to be a motivating factor. There had to be a reason that you decided, "Hey, we need to do something about that." And what was that? What was the motivator or driving force that prompted that ad campaign?
One, the fact that Butte County still struggles with getting mental health and addiction out of the shadows and getting people help. Two, we had a grant, a CCMU grant that helped fund that and allowed us to spend that money. And three, that grant was going to be cut very shortly.
Okay.
And if we had kept that grant going for some of the other things that we wanted, we would most likely have lost that funding.
Yeah.
And so it was an appropriate use of funds to raise awareness about mental illness and to add resources and awareness about crisis services. And we thought this is a good idea. We didn't just come up with the ad campaign on our own.
Okay.
We hired an ad firm. We had focus groups, both community members, staff, and consumers of our services. So it wasn't done in a vacuum.
For sure. Yeah. Well, and how does Butte County compare to other counties in terms of the need for that kind of service or that kind of community outreach?
I'd say every county could benefit from it.
Yeah.
The more rural you get, the more need you have. The more rural, the more high scores you have, the more addiction issues you have, the more mental health issues you have, the fewer resources you tend to have.
Yeah.
Although I feel like Butte County is rather blessed as far as the number of resources we have for our county size is pretty impressive compared to other counties that are comparable in size.
Sure, but when you compare it to other areas, it's still sometimes challenging to get providers and people who are willing to come up here and treat our population. It's not always easy, right?
Absolutely. We're a health shortage area. We've been designated that way, and we've done a lot of things to raise awareness about Butte County and to recruit people, including adding a psychiatric residency program, adding scholarships, loan repayments for people to come to work for us. And so we're doing a lot to try and bring people, particularly post-COVID, because that was a huge shift. Post-COVID, a lot of people went from in-person services to telemed or remote services.
Yeah.
And we had a robust group of psychiatrists and clinicians and counselors. And post-COVID, people decided, well, I can provide all those services over a screen, and I don't have to leave my house. And so a lot of people shifted to that, not just for Butte, but nationwide. Sure. And that also, I think, contributes to challenges with mental health. A lot of people don't like remote services or telemed services. They prefer to meet their counselor or their doctor in person. So if given the choice between an in-person visit with a clinician and a telehealth visit,
it seems to me that being face-to-face with somebody is a preferable method to communicating, to evaluating somebody. Is the treatment as good if it's telehealth?
I would say it depends on the practitioner on the other side of the screen, but there are certainly some people who prefer that.
Okay.
Again, stigma.
Yeah.
They don't want to be seen walking into a clinic. They prefer to be in the security of their home and to talk about their issues, and also if they don't like something, click end.
Yeah.
Versus have a conversation and necessarily be challenged if needed.
Well, I guess my thought on that is I do think that face-to-face is probably a preferable or has benefits over the telemed. But if that is the only way that a person is willing to access it or able to access it, then certainly it does have value. I'd rather have that than nothing at all, right? Yeah. So getting back to the unpacking of your response as to why we're seeing an increase in mental health issues, you talked a little bit about the homeless population in Butte County, and there is a segment of the population that is resistant to the services that are being offered, resistant to the treatment that it might be available. They become the chronic homeless population. We talked a little bit about that, right?
Right.
Yeah. And how much does mental health or mental illness and or addiction factor into that very resistant population?
It's quite prevalent.
Okay.
And individuals on the street, the longer they remain on the street, tend to move towards addiction and or their mental illness or the development of a mental illness happens.
Yeah.
It's pretty traumatic out there. There's a lot of bad things that happen. There's assaults, there's hardships, there's extreme conditions, and there's boredom. And I don't want to underestimate that piece. Drugs feel good for people, and drugs pass the time for people.
Yeah.
And what you might start as something to just feel good becomes an addiction farther on.
Yeah.
And I think it's also part of I'm going sideways a little bit on you on the state messaging about drugs. In the 80s, it was, you see the frying eggs, and this is your brain on drugs,
Yeah, exactly.
bad drugs,
no.
don't do. Yeah. That was a terrible message. The scare factor. People like drugs. People like alcohol. There's a reason they're so popular. They feel good, but they come at a cost. And the longer you take them, the bigger the cost. And the more potent the drug or the alcohol, the bigger the cost. And again, as I mentioned with drugs in the 80s, when I was growing up, it's very different than now. Same with alcohol. When we were teenagers, we were happy to get a hold of some light beer.
A six-pack of beer.
Yeah,
exactly right.
It's a big party.
Yeah.
My kids are talking to me as they went through high school about, there's no beer at these parties, Dad. They're all hardcore. It's hard alcohol mixed in with some kind of fruit drink.
Yeah, right.
They're powering through hardcore liquor that most people in my generation didn't necessarily do. So there's a lot of people using a lot of things right now. And so getting back to the street, they're also using a lot of those substances and getting addicted.
Yeah. You mentioned boredom, and I wonder, in my mind, that kind of equates to this basic human need for us to have purpose in our life, right? You have to have some reason to get up in the morning and something to work for or to achieve, because that provides that kind of natural high or that natural dopamine release. But if you don't have that and you turn to drugs for that, as you mentioned, it's a temporary solution, because eventually the drugs you're taking stop giving you the same euphoric feeling that you initially got, right? And so it drives you deeper and deeper and deeper into that. And then there's a whole host of mental health and health-related issues that come with that.
Right. And this, on the other part is, not only do you chase the high that you used to have, that first hit felt so good, your brain chemistry changes, and when you go off the drugs, the dopamine receptors and the ability to feel content or normal is impaired.
Yeah.
So you feel miserable when you actually go off the substances. And that's one of the big struggles for addicts or duly diagnosed individuals coming for us for services. Is historically it was like white knuckle it, the AA model, just stop using, feel like crap for a while, and then you'll get better. Is no, there's now some resources, medication to help you with side effects, to help you feel more stable, that we can provide to addicts to help them come down off the substances. But they have to want the service.
Yeah. That's called medically assisted treatment?
MAT, you got it.
Got it. Okay.
Yeah.
Okay. Which is something, maybe we'll get into that in a little bit here in terms of our efforts to try to make that available more widely, especially with people who are intersecting with the criminal justice system. Last piece on this, and I recently had a bit of a debate with a state official over the intersection between drug addiction and homelessness. And one of the things that this person kept saying was, well, it's just a shortage of housing. So if we would just solve the shortage of housing problem, if there was more housing, then that wouldn't be as significant of issue. And granted, I think there is a shortage of housing here in California, especially in Butte County, and we do need to deal with that. But is it as simple as just saying if we had enough apartments, enough places for people to live inside, they would gravitate towards that and we'd be able to solve the problem?
In my world, I call that magical thinking.
Okay, I like that. Okay.
Yeah. It's the belief that if you just do this, things will get better.
Yeah.
And it's also the premise of the housing first model.
Okay.
The state model, which really pushes hard, get someone into housing. If you get someone into housing, regardless of if they're addicted to substances or they're mentally ill or they're both, they will magically decide, I'm ready to get treatment and step up and embark upon voluntary services. That is the extremely flawed model. Someone who's lost their job post-campfire, who's struggling and desperate to get into a house, that's a different story.
Yeah.
They're not addled with addiction issues. They don't have the anosognosia, but they have no insight on their illness, things like that. San Francisco's housing first model, I think, is a great example.
Okay.
In my opinion, it's a failure.
Okay.
You are seeing on average 12 people a month dying who are being put in the housing first model. You have someone with a severe addiction, untreated mental illness, plucked off the street, offered a shiny new apartment, and told, here you go. That person on the street has a history of perhaps overdoses, and they're with their buddies, and they're in a campsite, and there's Narcan available to reverse the overdose. 911 gets called. Someone sees something. Now they're in an apartment, still in the throes of addiction, still their prefrontal cortex all about, give me drugs, I want drugs, I want drugs. Now they're overdosing behind their bright, shiny apartment closed door.
And nobody sees it.
And they die.
Yeah.
And a couple days pass, someone smells something, or someone hasn't seen the person, and they get into the apartment and they're dead. You cannot put an addict or someone with untreated mental illness into a house, I don't care what the house is, without supervision of some kind.
Yeah.
So our philosophy, at least from behavioral health, is yes, housing first works for people who are at a place where they want it and they're stable and they're engaged in treatment. But if not, don't put them in a place without supervision.
Yeah.
Which is why Everhart Village, the tiny homes, or our licensed board and carers, or our crisis residential programs, they have a component of supervision and oversight to help these people as they transition off the streets.
Well, and it goes back to what we were talking about a little while ago, which is, drug addiction, mental health issues. Sometimes they're co-occurring. Sometimes it's hard to say which caused which. But if a person is suffering from those to the point where they can't manage their day-to-day affairs, putting them in a house where they've got to take care of themselves, cook, clean, perhaps, navigate, paying bills, to whatever extent that is. In some respects, I think you're setting them up for failure if they are not at a point in their recovery that they can handle the pressures of that. Is that a fair statement?
Right. Plus, if you're Butte County Behavioral Health and you have to find housing for individuals and perhaps fund it, which the state is pushing us that direction, if you don't own that apartment complex that person subsequently destroys, carving holes in the wall because they believe there's microchips or bugs or tracking devices, or just destroying the place because of the addiction, or they're bringing their friends over, you destroy your relationship with that apartment complex manager. That manager talks to his friend, another manager, and all of a sudden you're blackballed from any placements of behavioral health clients.
Right.
So the housing first model, where you continue to fail, just also blackballs behavioral health from partnering with some providers. So we are forced to actually acquire buildings ourselves now, have an independent manager and a rather robust property maintenance crew to fix broken windows and things like that. And I'm not saying that every mentally ill or addicted person does this, but the extreme examples set the stage, and that's the narrative that you hear whenever we try and put a new facility, a new housing project in the community. Someone's got one of those stories that they go, this is what all your people are like.
Yeah.
Hence the stigma.
So you bring up another topic, and you and I have talked a lot about the challenges of finding locations to place people with the proper support so that they're successful. And you talk about the need to actually purchase properties, but then you run head first into the not in my backyard problem, right?
NIMBY for short.
NIMBY for short, exactly right. And we've had a lot of conversations about this and trying to find solutions for people with significant mental health or addiction issues who have come into the criminal justice system, and we're trying to break that cycle, address the underlying causes of their criminal behavior, and trying to find a place for them to stay. And I hear this, well, I don't want them around, I don't want them in my neighborhood, or I don't want them around this, or it's too close to this school or this park, or the case may be. And my response often is, well, they're in your neighborhood anyway. Right? And wouldn't it be better for us to have an environment where we can make sure that they're receiving the services and treatment they need, but also being monitored so that if it gets too bad, there can be an intervention that doesn't result in somebody getting hurt?
Yes, right? That sounds logical, but that's not how the community thinks.
Yeah, I understand that.
You have one or two, and this is just the terms we hear.
Yeah.
There's one or two crazy people in my neighborhood that I have to deal with, and I see them every day. This is not me talking. This
I understand.
This is talking.
What you get. Yeah, okay.
And I can manage them. I can avoid them. I can tell my kid to go on the other side of the street. Now you're talking about putting 8, 10, 15 of them in one area in a house. That's going to cause chaos. They're going to rape my kids. They're going to destroy the neighborhood. My property value is going to drop. That's the mentality that goes with that. Instead of what you just said, which is support, supervision, treatment. Isn't that better than them wandering the streets causing chaos?
Yeah. It's a tough situation, and I know we're working on a couple of programs right now to try to deal with that, but it's a challenge for sure. All right, so let's talk about how we intersect in terms of behavioral health and law enforcement on the streets. And generally speaking, that's when we get calls that someone is a danger to themselves or others because of a mental health issue, perhaps they're suicidal. Generally, that's the way it comes in. I know now you're getting those calls as well, and I want to give you an opportunity to talk about that. But that is where there is a co-response opportunity between behavioral health or mental health clinicians and law enforcement. And we have had a co-response model to some degree or another here in Butte County for, 10 years now, maybe?
I'm going to actually look it up because I remembered I wrote it down.
Okay, fair enough.
Give me 1 second because I actually... since 2018.
Okay, 2018.
Yep.
Okay, all right. And that was started somewhat informally between your predecessor and...
Yeah, my former director, Dorian Kitchell.
Yeah.
And it was between behavioral health and Chico Paradise, or Chico PD.
Yeah. And then we had an opportunity to get involved in that. And from my perspective, it was working really well. It was a good program.
Started off a little rough. I think partly because law enforcement was not used to behavioral health.
Sure.
They actually wondered in some cases whether or not we were spying on them and reporting their behaviors. And I get a chuckle out of it now, and so do they. But yeah, as trust was built and we co-responded, I think things started to really click.
Yeah.
And we had some really good encounters. And then we tried to spread that out, and we did, to the sheriff and to Orville PD, Gridley PD, and Paradise PD.
Yeah.
And the co-response model, I think, was great because it was almost on-the-job training for your staff and my staff to understand each other's worlds, and also to work with people on the street with addiction and mental health issues.
Yeah. I know that, once we started doing it at the sheriff's office, my staff became really supportive of it and really appreciated or valued having the ability to call a mental health clinician into a scenario where we're dealing with somebody who was suicidal or who, was clearly in crisis because of a mental health issue. And it got to the point now, it's the point now even where if my dispatchers are getting information from the callers that would indicate that there's a mental health issue, almost immediately we're reaching out to your department to see if there is a crisis response unit that can accompany us there. There were some changes recently, though, in the whole program, right? The state intervened and made some changes. Is that
Are you referring to the transition to a required 24/7 program?
Yes, exactly.
Yes.
Yeah.
So,
yeah.
Not this year, but last year, the state required all county mental health programs to operate a mobile crisis team, 24 hours a day, 7 days a week. Resources, pending.
Yeah.
And to have the opportunity for the community to call an alternative number to 911 if they had a family member or they were in crisis, to see if behavioral health could roll out.
Yeah.
And due to a number of negative encounters with law enforcement and people in crisis, that led to poor outcomes.
Uh-huh.
And the thought was, well, if mental health professionals are the first line to respond, maybe there won't be as many negative encounters, maybe all the way up to leading to death in some cases.
Yeah. So let's start. Did the state properly fund that?
Interesting enough, the state did provide augmented funding. So
Okay.
I would say this is one of those times I'd say yes, they provided funding for it.
Okay. The time frame under which they wanted you to get the program up running, did it give you enough time to get it going?
That was complicated. It was less than a year for us to do that. The challenge for us was staffing. Hiring individuals for our mobile crisis teams represented a lot more challenging situation than just hiring someone for an outpatient position. Mm-hmm. You're asking people to work weekends, overnights, holidays, versus an 8 to 5 position. So we had and will continue to have some difficulty filling those spots in the overnight weekend positions.
Yeah. That staffing is always a challenge, especially when you're dealing. I have the same kind of thing, trying to hire people to be deputy sheriffs or correctional deputies, especially given the stress, the workload, the having to work shift work is very, very challenging. And especially, I think, in our part of the state, because our applicant pool isn't nearly as big as, say, the applicant pool in the Bay Area or Southern California. So I think it creates certain challenges, and I think you're seeing the effects of that as well.
Yes.
Yeah. So one of the things that I saw, or the perception I have, was a program was essentially the state asserting that, or disincentivizing a co-response by law enforcement. The default being that all of the majority of this should go to mental health, and only under certain circumstances should you involve law enforcement. Is my perception accurate, or is that?
Yes, there's definitely bias towards not having law enforcement respond.
Yeah. And if that's the case, so what's your view on why don't we just send mental health clinicians to all of these and just keep law enforcement out of it?
In cases excuse me, in cases in which someone is in crisis and asking for help, I see that as an appropriate response.
Okay.
However, crises are never as simple as that.
Sure.
There are frequently cases where someone is in a mental health or drug-induced crisis. They are not necessarily able to determine reality from what's going on.
Yeah.
There's sometimes violence involved, high degree of paranoia sometimes, and weapons.
Yeah.
And in those cases, I don't care how skilled I am as a clinician or a counselor, I can't go out and talk someone down who's very high on meth and running around incoherently and not able to have a meaningful conversation.
Yeah.
In a case like that, there's safety issues that need to be considered.
For sure.
Where we have really valued having law enforcement alongside with us for those cases.
Yeah. Especially when there is a understanding of respective roles, and we've worked to provide our deputies with a lot of training about de-escalation and understanding people who are in crisis and working cooperatively with people. And when you can bring both skill sets to the situation, you're in a much, much better position to resolve it with the positive outcomes, as opposed to just sending one professional with a certain skill set in to the exclusion of other professionals who may need to be there as well. Right?
Right. I'd attribute that to having a team approach.
Exactly.
At any given time, members of your team can step up and do things, and sometimes if they're not the right person to engage, and the other team member should be involved.
Yeah. You bring up a kind of interesting point, which is I think dovetails into this whole concept of de-escalation. And at some point, I'm going to do a podcast about de-escalation. And I will say that de-escalation, in my view, is a tragically misunderstood concept. There's this notion that de-escalation only involves talking, and that if you just talk to people, you'll be able to calm everything down, and there will be no need to utilize force or force somebody to do something that they wouldn't otherwise want to do.
That would be also called magical thinking.
That would be magic. Exactly right.
Yeah.
Because it's not reality. Right?
Yeah, and you continue to see that where we've had negative encounters in the community with law enforcement and people screaming about, had behavioral health been there, first on the scene, nothing bad would have happened. And it's like, I have some very talented and skilled staff, and they do a really good job. But again, when someone is completely checked out from reality and does not want to talk and is waving a machete or swinging a weapon, I don't care how much talking you do, they're not necessarily going to be engaged in a meaningful conversation to de-escalate. For sure. And that's why I think it takes the team approach. And it's unfortunate when people engage in, as you say, magical thinking. It oversimplifies it. It becomes a barrier to us finding solutions to problems. And there is a problem in believing that you can guarantee positive outcomes 100% of the time. It's just not realistic, right? Correct.
Yeah.
Now, in defense of some of those encounters, there have been cases in which law enforcement has come in pretty aggressively and not necessarily done some of the de-escalation techniques or gone from 0 to 60, and there have been negative outcomes. I wouldn't speak to that in Butte County, but in other counties, which is, I think, behind any good, intended law or new change the state does. There's usually some reasons for it.
Well, yeah. The problem with the state's approach is they tend to try to fashion these one-size-fits-all approaches, and it ignores the fact that there are differences throughout California in terms of populations and demographics and local conditions and local resources and partnerships and things of that nature. And I would also, submit to you, and I think that you're probably in the similar boat, is that every single day there are thousands and thousands of encounters between law enforcement officers and members of the community, or for that matter, mental health clinicians and members of the community that that end positively, that are achieve the result that we ultimately want to achieve. And it's only the rare exception that it doesn't go that way. But those are the scenarios that get pumped into your news feed, right?
Yep.
And you begin to think that, oh, well, that's the way it is all the time, to the exclusion of the tremendous work that is being done by people in both of our professions on a daily basis that goes completely unnoticed.
Yes, I would love to share some of the videos, and I'm sure you would, of those positive encounters where someone looks like they're having a really difficult time and they're de-escalated through the teamwork between law enforcement and behavioral health. The outcome's good. They agree to care, or we're able to get them into the next level of care. But confidentiality exists and all sorts of things that are barriers to that.
Right. And then, as part of the things that, sensational stories are the ones that get clicks, and those are the ones that get, pushed out. And
the feel-good stories are the last 30 seconds of the news segment.
Exactly.
Where people are already checking out and going to, get a soda or something.
Yeah, for sure.
But what you're talking about, the state making one-stop decisions, is the next big thing happening to behavioral health because of all these situations. Next year, the state is really pushing us to focus on solving homelessness. Removing homelessness and housing all the homeless individuals.
Okay.
And one of my biggest funding streams, the Mental Health Services Act, is essentially being hijacked and we're being forced to spend 30% of that money on housing for individuals who are either chronically homeless or have homeless issues. Sounds great, but I'm cutting 30% of my services starting next year. A lot of the services that are preventative, early intervention services, critical services that help offer a buffer and prevent people from becoming homeless. So there's some big changes coming to behavioral health. There's some other things too, but when you're talking about the state just looks at the negative and goes, okay, we're going to do this and apply it to everyone, that's an example of what's about to happen.
Which, again, this is a problem that the state has been battling with for years, and now they're shifting the responsibility onto the counties and asserting that the counties have been, failures at the whole thing. It's really frustrating, because I saw it happen in criminal justice with AB 109 when they shift responsibilities to the locals. And then now, there's a lot of criticism about, how we were able to do the things that we're doing or what we're doing. So it is frustrating. Before we leave this whole co-response thing, I want to talk a little about this. So the co-response model was in place here in Butte County. We'd worked through the bugs. As a matter of fact, we still meet on a monthly basis, your department and mine, work through issues, try to figure out, how we can improve the process. And then along comes a appellate court case called Scott v. Smith, right?
Out of Las Vegas.
Exactly right. Yeah, out of Las Vegas, involving the Las Vegas Metropolitan Police Department. And just a quick recap of the facts of the case so that everybody's kind of up to speed on that. Individual calls 911 asserting that there are people within his apartment that are trying to kill him. They send a couple of police officers. They get there. Police officers are able to see inside through the window. There doesn't seem to be anybody in the apartment with this individual, despite the fact that he's asserting that they're intruders. They're reluctant to go in. They want him to come out. There's some conversation between the two of them and a supervisor about the fact that his behavior indicates to them that he is having some kind of mental health crisis. Eventually, they convince him to come outside, and as he's walking down the stairs that leads from his door to the area in front of his apartment, they notice he's got a pipe in his hand. They ask him to put it down. He does. They get him outside. They ask him if he has any other weapons. He says, I have a knife, pulls it out of his pocket, hands it to the officer, but then talks about him having, being paranoid. I think he may have said he had schizophrenia or some pretty significant mental health issue, and requests to just be put into a car. He just put me into a car. The officer is concerned that he might have other weapons, decide that they want to conduct a pat-down search. When they do so, he begins to pull away, becomes somewhat resistant. They put him on the ground. They apply pressure to the top of his body, body weight pressure against his body and to his legs. Eventually get him handcuffed, but he starts expressing that he's got some distress. And then, unfortunately, regrettably, he passes away. So the family of the decedent sues Las Vegas Metropolitan Police Department, and it goes up to the Ninth Circuit. And the Ninth Circuit ultimately concluded that the use of force wasn't reasonable under the circumstances, given the other cases that have been previously decided with regard to how much force an individual can use in a various situation. So that's the backdrop. And then some colleagues throughout the state of California decided that put officers at too great a risk for civil liability, and made the announcement that they weren't going to send law enforcement officers to situations involving people with mental health crisis, and therefore essentially undid or interfered with our ability to co-respond in those jurisdictions. Is that your understanding of that as well?
Yes.
Yeah. And we've talked a lot about that. As a matter of fact, there's a jurisdiction here in Butte County that has decided not to co-respond under those circumstances, correct?
Correct.
Yeah. And the challenge, of course, is that in my view and looking at it, it's a use of force case that requires officers to do what they've always been required to do, which is evaluate the circumstances and make a determination as to the appropriate level of force given the circumstance you're dealing with and the individual's resistance and a whole host of other factors. But if you just make a blanket rule that you're not going to respond to a citizen who we serve in our community who is in crisis and be willing to partner with other professionals to help that individual and help the people who are around that individual, causes me a lot of concern. I just don't believe that's the right approach. What's your view on that?
I agree. I was really concerned when I learned one of our jurisdictions was not going to co-respond with us anymore on mental health crises, and decided that if it's a mental health crisis and a law is not being broken, it was our responsibility to go out and respond. I was even more concerned to learn that we go out, we intervene with someone, excuse me, and we determine that they need to be hospitalized due to being gravely disabled, danger to themselves or others, and they're not willing to get in our car to drive them to the hospital. Historically, law enforcement would have assisted us with that. Now that organization is refusing to put that individual in the vehicle and saying it's not our problem. So I have individuals now that are in mental health crisis that are also unwilling to get care, that I basically have to tell my team to document everything we've done to try and intervene and de-escalate and then walk away, leaving that individual still in mental health crisis, potentially still suicidal or homicidal, and potentially bad things will happen in that community.
Yeah, that's the concern, isn't it?
Yes.
Yeah, ultimately.
And we've had a relationship with law enforcement for years where we've co-responded and we've had roles and responsibilities. We have an MOU, and this is a game changer.
Yeah.
And I think it's a bad decision, and I think it's going to lead to some significantly negative outcomes, be it death or someone seriously hurt. And at some point, the law will have to look again at that legal decision.
Yeah. Now, I will tell you that I think in many respects it's a wrongly decided decision by the Ninth Circuit Court of Appeals. I don't think that they took into account the challenges that law enforcement has. And it's something that ultimately I'm hoping that this U.S. Supreme Court will take up. I know that they have granted the defendants in that case more opportunity to brief it. So hopefully they'll take that up and we'll ultimately get to that thing. Senate Bill 43.
Yes. Another big change next year.
What's that about?
That is the state's changing of the Lanterman-Petra Short Act, which is a 55-year-old law around who is considered gravely disabled. The law as it stands or stood was you could be considered gravely disabled if you didn't have a means to feed yourself, clothe yourself, or house yourself because of your mental illness. A large portion of the individuals on the street, however, and or living in situations, but mostly on the street, also suffer from addiction issues and or are so wrapped up in their addiction or mental health issue that they're not taking care of their physical health issues. So the law expands the definition of grave disability to allow behavioral health entities or law enforcement to write 5150s for individuals who have a severe addiction issue causing their inability to find food, clothing, or shelter, or their mental health or addiction issue interferes with their ability to understand the fact that they have an untreated medical issue, open wound, untreated diabetes, things like that. And without getting that medical care, negative consequences, including up to and leading to death, could occur, and that we could intervene and consider them gravely disabled.
So I see value in intervening in those circumstances because clearly I think if people have gotten to that point, they need something to motivate that or push that forward. But that's going to put a lot of burden on the system, isn't it?
Absolutely.
Yeah. And
especially as we just talked about not being able to coerce individuals into treatment.
Yeah.
If you don't have the means to put them in a vehicle in some kind of secure setting with law enforcement support.
Yeah. To fully implement that, it's going to require collaboration between behavioral health and law enforcement. And I suspect that there's going to be a whole host of pressures on an already on a system that is already at its max. Is that a fair statement?
Yes, and it's going to really impact the emergency rooms.
Absolutely.
Because people with untreated medical issues that are that severe coming in and needing to be medically cleared to be hospitalized are going to be sitting in that emergency room for a long time.
And the challenge is that unfortunately emergency rooms often become the primary access point for a lot of people with a whole host of medical conditions that aren't actually emergencies.
Yes.
And that creates a problem because now those limited emergency department resources are having to triage that, wade through all that, and then focus in on the people who actually need emergency care.
Right. And you're including a population that doesn't want help. So a number of those individuals are going to abscond or leave the emergency room.
Yeah.
And who do you call when that happens? Law enforcement.
Exactly right.
And if law enforcement doesn't want to involve themselves in that, you'll have a lot of people wandering around the streets who've been on 5150s who are not willing to get care.
Right. Which has an impact on public safety overall.
Correct.
Yeah. Scott, is there any one thing that you would like to let the citizens of Butte County know with regard to behavioral health or mental health? If there's one parting comment that you can make, what would it be?
You're only giving me one comment.
Well,
All right. I'm going to get a very long run-on sentence.
Okay.
I have an amazing group of staff that do some really hard work, and I want to acknowledge them and all the work they do. I also want the community to please be sensitive and aware that when we are finding or looking for new placements for individuals in the community, we're taking into consideration where these facilities are and neighborhoods and things like that. But we're also treating your friends, your family, your neighbors. So it's important for you to recognize we're trying to get you some help. And then the last piece is, in the news, you keep hearing about millions and millions of dollars in funding coming to counties to add more beds. And there's a recent funding stream that we got to help us open a locked 40-bed facility.
Right.
That money is for bricks and mortar, as they say, to acquire buildings. What the state is not giving counties is operational funds. So I can build a facility, but I still have to pay to rent to operate it. I have to pay the provider. I have to staff it. That's millions and millions of dollars. So when the community is like, what's behavioral health doing with all this money? Every time I add a new treatment program, a new facility, a new team, there's costs attached to it, and there's no new money coming from the state, so I'm cannibalizing other areas to make that happen. I just think that's a big misperception the community has about what behavioral health can and can't do. And so any kind of future bills that talk about adding more beds need to include funding to provide daily operations.
Absolutely. It's so frustrating navigating this and having mandates put on us by the state, but not the adequate resources to follow through them. So
yeah.
I really appreciate that. This has been a fascinating, and I think we could probably go on for another hour talking about all the intricacies of the mental health system and the intersection between that and criminal justice and public safety. But Scott, I really do appreciate you taking the time to come down here and talk to me about some very complex issues that impact public safety directly. And I want to just tell you that we're going to continue to work as collaboratively as we possibly can with your department, because at the end of the day, I want everybody in our community to be safe, those people dealing with mental health and drug addiction, but also the people in the community that are impacted by that as well. So thank you very much. I appreciate it.
And I applaud you having behavioral health as a topic. It's not something law enforcement always wants to hear about, or the community, and I think the more we get out there and talk about behavioral health issues and raise awareness, the better. So thank you very much.
Absolutely. Thank you, sir. So that's it for this episode of the Sheriff's Mic. If you enjoyed it, I'd ask that you like it and share it and tell your friends and family about it. The more people who know about it, the more we're able to get this very interesting and I think and valuable public safety related information out to the community. If you would like me to take on a topic or have a guest, you can email me at sheriffsmike@buttecounty.net. And until next time, stay safe, stay informed, and as always, you're cleared to talk.